will know if you are or know people are smoking is that very many people are able to overcome a deeply dependent aspect of their behaviour. And I think that is true in relation to other forms of drug use. Now, there are many kind of inconvenient findings from research. So HIV is a greater threat to public health than drug misuse. Well, these are the figures of new cases of HIV amongst drug injectors tested in England, in Scotland and the rest of the UK. So you can see from 2000 up to 2009, we're talking about just barely into double figures. New cases, 17 in 2000 and 13 in 2009. The rest of the UK amongst injectors tested, 85 in 2008. So we had certainly massive anxieties about an overwhelming epidemic of HIV that's going to be driven substantially by the spread of HIV infection amongst injecting drug users. That is the situation now that we face. They are tiny numbers. Each one, of course, is a tragedy, but they are tiny numbers, and they are nothing like the epidemic that we feared at one time. What about drug use over a similar sort of time? Well, these are the figures in drug use now. So, Glasgow, 1982, an estimate of around about 1,400 drug use from, done by Jason Ditton. And I know when Jason announced those figures, there was shock horror at that result. People just simply did not believe that in this city there could be 1,500 problematic drug users. Well, by 1985, that figure had gone up to 5,000. By 2006, 13,000. By 2006, the estimate for Scotland, 55,000. World Drugs Report identifies that Scotland has a drug problem per head of population bigger than anywhere else in Europe. So the epidemic that many people feared in the late 80s was going to be about HIV actually turned out to be about drug use. The figures that we see in terms of drug use overwhelm what anybody expected would be the case 15 or 20 years ago. If we had said we're going to have an estimate of 55,000 problematic drug users in Scotland, and currently, if we'd said that 15 years ago, nobody would have taken us seriously. Everyone would have said, you have got to be crazy. There's absolutely no way that Scotland is going to see those sorts of figures. But that is exactly what we've seen. Is it possible to get people off drugs, or is the best that we can do to enable people to use drugs with greater degree of safety, less harm? That is the view which has really shaped policy for many, many years in Scotland and the rest of the UK. Injecting risk behaviour. Now this is an inconvenient finding. This is needle sharing in the last month in England and in Scotland. You see the figures there, 31% in 2000 passed on needles in the last month. Now that figure for 2008 is down to 19, which is a reduction, but it is not a massive reduction of the scale that would be needed to actually forestall major bloodborne epidemics. Positive in relation to HIV, but I'll show you the figures in relation to hepatitis C. And the figures in brackets are for the younger drug users. So we are failing largely to bring about the order of reduced needle sharing that would be required to stop a major bloodborne epidemic. But that has happened in relation to HIV. These are the figures for hepatitis C. So you see in Glasgow, the latest estimate of 63%. In England and Wales, 47% for 2009. We have seen, and are living in the midst of, an epidemic of hepatitis C infection at a time when we have had a massive investment in harm reduction initiatives. Now nobody can be of the opinion that we have successfully stopped a bloodborne virus epidemic. We haven't. We've actually missed, we stopped one and we missed another one. And that in a way, it seems to me, shows some of the difficulties with harm reduction. We can pat ourselves on the back that we avoided one epidemic, but whilst we're doing that, we actually saw another one overwhelmed in terms of those figures. There's little or no prospect of recovery from dependent drug use. That is something which I hear time and time again. It's pointless having services focused on getting drug addicts off drugs because the majority of people will not manage to do that. We've become used to the idea that 3, 4, 5% of people will become drug-free on the basis of the services that we provide. Well, here's an inconvenient finding about drug-addicted doctors in America who were tested randomly, regularly, to find out had they managed to recover. And yet 81% of those completing their treatment remain drug or alcohol-free over the 5-year study period. 80% of doctors who were addicted to alcohol or drugs entered this treatment program, became drug-free. And that was established on the basis of random and regular urine testing. And then you say, well, that's doctors, isn't it? And they would achieve becoming drug-free. That's not what services is going to achieve with other people. And there is a degree to which that may be true. But why do we say it about doctors? One of the reasons we say it about doctors is you say that they've got an investment in actually coming off out of their dependency. It actually is important for them if they're going to continue to be able to practice. But what does the perspective of harm reduction have to say to drug users who are looking for abstinence? Well, this is one of America's most notable harm reduction influence physicians. And he says, addicts who embrace an ultimate goal of enduring abstinence should be assisted in every way possible, and that's positive. But they must be advised with brutal frankness of the low prospect of success and the grim, potentially fatal consequences of failure. Now, if you heard that as a dependent drug user, I don't believe that would greatly infuse you or encourage you or inspire you to actually seek recovery from your condition, that actually the route of recovery may end up killing you. But that research with American physicians, which showed that over 80% could actually come off drugs and alcohol, what does it show you? Well, one of the things it shows you is that where individuals' motivation towards abstinence is high, and where services are focused on enabling individuals to become drug-free, then a substantial proportion of people can achieve that. But where individuals' motivation towards abstinence is low, and where services are not really focused on enabling individuals to become drug-free, then quite predictably the proportion of individuals who will become drug-free will, in all probability, be very, very small. Now, there are unintended consequences too of the harm reduction philosophy which has shaped our services. One of those is associated with methadone, a hugely controversial treatment. Absolutely no question, there are many benefits associated with prescribing methadone to dependent opiate addicts. And those benefits are evident in Scotland as they are elsewhere. One of which is reduced levels of mortality. And this is research which was published recently in the British Medical Journal. Opiate substitution treatment was associated with an increased duration of injecting. So methadone was helpful in reducing the numbers of addict deaths and the risk of death, but it didn't reduce the length of time people remained drug dependent. In fact, it was associated with a sizable lengthening of the time that people remained drug dependent, up to 20 years. So here we have a treatment which helps in keeping people alive, but leaves them drug dependent for much, much longer than they otherwise would. They otherwise might. Now I say that, having just recently been in Oslo, when I heard a presentation from one of the founders or one of the most influential people in the municipal health services in Amsterdam. And one of the things that he was saying is that in Amsterdam, the health authorities can congratulate themselves that they have managed to stave off an HIV epidemic and an epidemic of injecting drug use through the harm reduction initiatives that have been developed there. But they are also now looking at creating old people's homes for drug users still dependent on methadone. They realised what they did was that they surrounded drug-dependent individuals in Amsterdam, they provided them with methadone, and these individuals have continued to remain drug-dependent for many, many years. And they are moving increasingly now into old age, dependent on the medication that was originally prescribed to them to assist them. Now not everyone will say that that's a scary scenario. Some people will, some people won't. But there you see one of the worrying, unintended consequences of a treatment which is actually can help, but can also hinder. But we also see in Scotland an increasing proportion of addict deaths that are now associated with methadone. And there are parts of Scotland now where there are more drug deaths associated with methadone than there are associated with heroin. So we're now seeing 36% of addict deaths, I'm not saying are caused by methadone, but they're associated with methadone. So these are a proportion of addict deaths that are associated with the very drug that we were prescribing to actually reduce levels of risk behaviour and harm. And I think, in a way, it's because of those findings, those inconvenient findings, that policy has rediscovered the importance of recovery and abstinence. Our drug strategy in Scotland emphasised the importance of treatment services working to enable individuals to become drug-free. And that's the same thing for the UK drug strategy.